It's an honor and a privilege to be speaking before you all at this forum. I'll try and share some thoughts about how we can move towards equitable access of healthcare and what can be some approaches towards making insurance or insurance-like models accessible to the poor. So, let's just start with the burden of healthcare on the poor. Health is a dimension of poverty, and it's important to just look at it that if somebody is ill and has modest means, it will accentuate poverty. And what we have seen from studies is that a person from the poorest quintile of the population, which is the lowest 1/5 of India's population, despite more health problems, is 6 times less likely to access hospitalization than a person from the richest quintile. This is what the data has shown us, and most of this is government data from different ministries. Since I deal more with the urban segment of India's population, I'll make reference to that, but broadly, most of the challenges face rural populations similarly. But why urban becomes important is that we were talking, for example, a while ago about the number of hospitals between Safdarjung and Ashram, which is a city. And likewise, if we look at hospitals in Delhi, in South Delhi, or whichever district of Delhi, we often see that in urban centers, despite this presence of so many super speciality, modest speciality, primary care hospitals and clinics, still there are very large number of people in these cities who are not able to access these hospitals. And I don't know how many of you have experienced trying to access a hospital like All India Institute. I think anyone here who's sitting would not fall in the category of below poverty line as the Planning Commission says. But despite that, many of us must have encountered challenges in obtaining an appointment at All India Institute, or must have had to bot someone to call up somebody at All India Institute to facilitate an appointment. So these are the issues which, if we look at the lowest 40% of our population, they usually do not even have that person who can call for them. So you see people lying outside All India Institute or a Safdarjung Enclave or Safdarjung Hospital or other hospitals, and they do not get these access. The numbers in urban India are big. Planning Commission says that in urban India, 25.7% live below the poverty line, which makes about 100 million people. Now 100 million people in urban India are officially living below the poverty line. And how many percentage does anybody think would actually have below poverty line cards in urban areas? 10%. This is statistics not by any study with an NGO like mine has done. This is statistics from the Ministry of Statistics, Government of India, जिसका आजकल ऐड देखते हैं आप टेलीविजन पे, NSSO ऐड देखते हैं ना कि हमें जानकारी देनी चाहिए NSSO को, क्योंकि उसके आधार पे भारत सरकार सबके लिए योजनाएं बनाती है. तो उसी ऐड की जो एजेंसी है, उसी का स्टडी ये बताती है कि शहरी क्षेत्रों में भारत में 10% लोगों के पास बिलो पॉवर्टी लाइन कार्ड है. तो भारत सरकार की एजेंसी ने बताया, भारत सरकार की एजेंसी ने ही बताया कि बिलो पॉवर्टी लाइन 25.7% लोग हैं अर्बन इंडिया में. तो ये हम दिस इज द इशू व्हिच वी फेस. I'm just using below poverty line card data as an illustrative example to help all of us understand कि अगर हेल्थ केयर एक्सेस होगी तो उसमें भी ऐसे ही चैलेंज होगा कि सपोजिंग राष्ट्रीय स्वास्थ्य बीमा योजना पहुंचनी है इतने लोगों पर, पर पहुंचे ही कितने पर? जस्ट लाइक बीपीएल कार्ड पहुंचना कितने पर चाहिए था? ऑब्वियसली ऑल बिलो पॉवर्टी लाइन, बट इतने सारे सालों के बाद इट हैज स्टिल रीच्ड ओनली 10%. तो राष्ट्रीय स्वास्थ्य बीमा योजना या और जो बहुत सारी हेल्थ केयर योजनाएं जैसे जननी सुरक्षा योजना, वो पहुंचेगी कितनों के पास? इज व्हाट इज द इशू दैट आई एम ट्राइंग टू highlight before you, and I'll try and come up with some solutions. And why Janani Suraksha Yojana is important? Just among the urban poor, there are 2.7 million births per year. और इसके 3 या 4 गुना रूरल एरियाज में ऐड कर लीजिए. So 10 to 12 million births among the poor. And this is the poor which are officially designated as poor, living at that 32 to 40 rupees type of poverty line, which you must have read a lot in the newspapers about. So this is that segment, and if we take a little more, then obviously the number will increase. I mean, उसके ऊपर वाली layer को भी अगर include कर लें. This is some data which tells us that जो अर्बन और रूरल में हम डिस्टिंक्शन देखते हैं, और अगर if we take urban poor, then it falls far below. This is access to antenatal care and hospital deliveries. Urban poor access is far lower. This is access to a very basic service which जिसको टीका लगवाना कहते हैं, vaccination. Very basic service. Almost I think anybody sitting in this room would now even imagine कि दिल्ली में जो लोएस्ट क्वार्टाइल है, only 40 children out of 100 children less than 1 year receive this. दिल्ली शहर में भी. I mean, this is all India data, but incidentally हमारे कैपिटल का भी डेटा बिल्कुल यही है. That is the most recent data available, because NFHS 3 और नेशनल फैमिली हेल्थ सर्वे थर्ड राउंड के बाद अभी तक कोई और सर्वे हुआ नहीं है. तो अगर हम मान लेते हैं कि थोड़ा बहुत इंक्रीमेंटल इंप्रूवमेंट हो गया होगा, तो इट मस्ट बी अबाउट 10 परसेंटेज पॉइंट्स, नॉट मोर देन दैट इन 5 years, बिकॉज 60 साल उससे पहले की भी हिस्ट्री है ना हमारे पास. सो द इंप्रूवमेंट इज गोइंग वेरी फास्ट. Likewise, survival also among children less than 5 years is far less among this segment of the population, and undernutrition is very high. So these are all illustrative of the access of healthcare that is reaching to them, because that is the reason why you are getting children who are undernourished. क्योंकि हमारी healthcare access कम है. Now, what are the barriers? So this slide tells us that the barriers to access are lack of knowledge about where the services are, because many a times government or municipal corporations open dispensaries, but they operate so quietly so that that doctor doesn't have any pressure. I have seen dispensaries and doctor चुपचाप आके ताला खोल के अटेंडेंस लगा के 2 घंटे बाद चले जाते हैं. And it is very common, it's not surprising at all. I have been myself in the health system in government of Uttar Pradesh, a physician at a primary health center, and I have seen the system through, and I understand why this type of a thing happens, because sometimes a doctor comes from a distance which is about 2 hours to his workplace, तो वो तो कहता है मेरा दिन तो तभी शुरू हो गया, उसकी ड्यूटी तभी शुरू हो गई जब वो चल दिए घर से, और 2 घंटे उसको वापस जाने में लगते हैं. तो अगर वो वहां पूरी सेवा देगा तो वो रात को पहुंचेगा. So that is how these things operate, and there is some need to make this system more responsive. Now, what all can be done is, an issue which would require a lot of discussion. But these are challenges; these are practical, real challenges seen and observed by me myself. I actually go to these places, as Dr. Praneeth was saying. मतलब मैं इस टाइप पे ही काम करता हूँ, तो ऐसे डॉक्टर से मिल लेता हूँ, दोस्ती भी कर लेता हूँ, प्यार से समझ लेता हूँ, तभी मुझको ये सच्चाई पता है, क्योंकि उन्होंने अपनी जुबानी बताई है. एक डॉक्टर्स की मीटिंग तो इसी हॉल में हुई थी, where I was discussing this. That were those were doctors from the Delhi government and municipal corporation in this very hall. और जब थोड़ी देर बाद tension realize करी तो I kind of encourage them to relax and help us all come up with challenges. So because they realize that these are realities, sometimes we are able to open up and come with challenges. Another challenge is that slum context mein there is a large segment of unlisted slums or illegal or unauthorized or whichever way people have described that. Sometimes that also remains uncovered because of a strange notion in the mind of the authority that any slum which is not part of the official list is not entitled to healthcare, whereas that is not written in the Constitution of India. हमारे कॉन्स्टिट्यूशन में तो अगर कोई बाहर का व्यक्ति भी भारत देश में किसी वजह से रह रहा है उसको भी हेल्थ केयर मिलने पे कोई बाधा नहीं है, क्योंकि हेल्थ केयर देने के लिए यू डोंट इवन हैव टू सी द पासपोर्ट ऑफ दैट पर्सन. हमारे देश में ऐसा नहीं लिखा हुआ है कि आपको ये देखना पड़ेगा कि ये व्यक्ति कौन है और उसके पास सारे डॉक्यूमेंट्स हैं कि वो लीगल है या नहीं तभी देंगे आप. कभी आप में से किसी ने अनुभव किया है कि आपका कोई पासपोर्ट आइडेंटिटी सब कुछ मांगने के बाद ही डॉक्टर इलाज करता है? So this is a notion, but notions continue and they affect human beings, and I'm trying to bring all this to everybody's attention because they are affecting a very large proportion of the population of our country. Public health services are also inadequate, and I don't want to dwell much upon that. There is a need to augment public health service, do it in partnership with private providers or whichever way. But जो access है वो जैसे थोड़ी देर पहले भी बात हो रही थी कि जो आपने सवाल पूछा था डॉक्टर संजीव कि equitably distributed अगर होंगे then there is a likelihood that we will have more services which people can access. Now this is another interesting thing. Government has given a lot of subsidy on healthcare. And this data tells us that 77% of government subsidy on curative care goes to the 3 richest quintiles. Quintiles मतलब पूरे को 5 में बांट दिया तो ऊपर के 3 जो richest हैं, they are able to access 77% of all the subsidy. And I see some smiles, which means that people understand why this happens. Where is the negotiating power to get the subsidy? Discounts या subsidies लेने की negotiating power जिसको होती है उसको मिल जाएगी ना subsidy. Need के हिसाब से नहीं मिलती है. So often if in a hospital there is an option of getting a subsidy, whether it is for drugs or for an investigation or whatever service one is going, if you have the wherewithal within you to get that, whether you need it or you don't need it in terms of your needs, you will try and get it, and that is how this is what the data shows. So there again there is this mismatch, and it needs a multifaceted approach, a lot of thinking on the parts of those who are richer. Maybe they should themselves voluntarily not take such subsidies even if they are offered. Then how does, I'm talking about this because this links to insurance also, because we have to understand what should insurance cover. The cost of treatment is cost of transport, consultation fee, hospital admission, medicines, loss of wages. We tend to often ignore that. क्योंकि जो middle class salaried person है उसको छुट्टी मिल जाती है, लेकिन जो वेज पे काम कर रहा है उसे छुट्टी नहीं मिलती है ना. उसकी हम उस दिन की तनख्वाह काट लेते हैं मोस्टली. जो मजदूरी कर रहा है चावड़ी बाजार में ठेला चला रहा है और anything else that person is doing, that person doesn't earn for those few days. So that is also a cost, that is a burden on that person. And poor people are spending disproportionately higher percentage of their income on health than the rich. Now this is very interesting. When we see the monthly per capita expenditure on the basis of which our planning commission has come up with the poverty line, if you look at that report, which is available on the Planning Commission website, the last page of that report has a list of all the expenditure that person makes as a percentage. And we will see that the richer people make less proportion of expenditure on health, the poorer make a greater proportion of expenditure on health. So I don't know who is subsidizing whom. I mean, that's something which we have to think about. Now, here are some things which we feel could be explored. Now, these 3 slides I just run through because Nishant is the expert. He will deal with this far better than I will. I just place this for record just in case Nishant got busy elsewhere. So it's just dikhane ke liye hai. I'm not going to dwell upon these. These are various insurance programs which have been running in our country, which have eventually culminated in RSBY, which Nishant will talk about. But what are the challenges of all these schemes? Often they are excluding the cost of drugs. Often they are excluding the cost of diagnostic tests, or if not excluding, trying to get that test done either by a cashless mechanism or getting reimbursed is very complicated if you are not hospitalized. So those are issues. Consultation, OPD is often missed in most insurance schemes, and chronic illnesses are often excluded from most insurance schemes. And therefore we realize that there is a need to rethink whether insurance alone or something which is like a one size fits all approach is really going to work for this large diverse nation, or we need to have more creative ways to think about this. Which is what we were talking about a while ago in Dr. Kaul's presentation. In Dr. Kaul's presentation, which talked about needs, need-based treatment की बात वो भी कर रहे थे. यहाँ भी अलग-अलग category of people have different needs, and how is it that we can handle that? So one approach is community health funds, which we have a lot of experience with, where communities have saved in a collective pool, and they have been using that collective pool for health emergencies. These are women who are writing this in a register. This is a money box in which they keep the money. These are their records. जो lower right hand पे एक passbook भी है, वो they maintain it themselves. And there are about 120 groups representing 3 lakh slum dwellers in Agra and Indore, and they have a total revenue of approximately 20 lakhs, which is revolving among the population as loans. And in the last 2 years, about 2,000 loans have been disbursed for health care, about 2,000 for education and other social needs, and 1,000 for livelihood. और इसमें किसी ने कुछ सब्सिडी कुछ नहीं दिया है, सब कुछ उनका है. हम लोग सिर्फ उनको हैंड होल्ड, मेंटर और ट्रेन करते हैं. And there are similar examples in Pune, Mumbai and Bihar. The other thing which we have tried is a private, socially committed, मतलब not totally free, 800, 900, 1000 रुपए ले ले, but this doctor is socially committed. He provides maternal child health camps once a month to the people, and this is another approach which people are paying 10 to 15 rupees for availing the service. And at least that is reaching them, and the women's groups which we just saw pictures of those women, they are facilitating access to these schemes. So the public sector has to strengthen and increase its outreach. It has to reach out to the people, not expect कि यहाँ facility बन गई तो ये सब लोग पहुँच जाएंगे अपने आप और सब कुछ equitable हो जाएगा अपने आप, access to the masses हो जाएगा अपने आप. It does not happen like that. You have to ensure that. In the private sector, if there is more social responsibility, again with outreach, and I know very soon Dr. V.L. Kapoor Hospital is going to start some outreach activities in some 4 or 5 designated areas of Delhi. So that is one example where hospitals in the private sector can reach out to the areas where the need is and increase access of people to the healthcare. And these health funds, which we talked about, is another suggestion. In insurance, what we realized is that the product has to be based on discussion with the people for whom it is being created. The challenge in a country like India is that everything is managed centrally and the model is developed with very good intention and a lot of creativity, but the people for whom it is being done, it is not modeled with them or by them. If the insurance model would be developed by the poor people, then it would be perhaps more addressing their needs. So the first option is that discounted outpatient consultation, discount on drugs, free checkup and annual hospitalized expenses. Cost, which people suggested, these three models which I will share you, these are suggestions from people belonging to slums. This is not my creativity. They wanted to cost approximately 50 paisa to 1 rupee per person per day. Outpatient benefits similar to the above. Cashless hospitalization for empaneled hospitals wanted to cost about 1 rupee per day. Third option, 1.25 rupee per person per day. So what this tells us that this is the approximate amount. These are the services that they are facing difficulty in accessing, and this is what they need. And if we are able to develop an approach to address their needs, it would perhaps be better. Let us all try and work together to bring about improved access to all the disadvantaged segments of our country's population. Thank you.